Thank you. Good morning, all. I'm Sanne Smith from Groningen, Jolien Veraart from The Hague, and we also have Robert Schroefs with us from Groningen. And in the next 10 to 15 minutes, we'll tell you about our studies on oral esketamine and also about our off-label treatments with esketamine. We received the funding from our government to conduct our RCT, and Jolien received some honoraria from Janssen, but it was outside this work. Before I start with our RCT, I'd like to give a brief introduction about why even bother about oral administration. As we've seen yesterday, there are so many good results when looking at the intranasal data, when looking at the intravenous data. So why even bother about oral administration? And we think that there are, among other reasons, two important reasons, and that's the money. Because treating patients with oral ketamine is so much less expensive compared to intravenous and intranasal treatment. And also, as we've seen in the previous presentation, it makes it easier to give the treatment at home if it's possible to give patients the oral treatment. So that's why in 2015, Robert conducted a review or reviewed the literature to have a look at the results back then about the oral administration of ketamine in patients with depression. So what did we know back then? Well, not that much actually. He found 5 uncontrolled studies, and they were all open label. Sample sizes were small. However, it was interesting because all studies did indeed find the relief of depressive symptoms in patients with depression. So that was quite interesting. So even though there weren't many studies and sample sizes are small, it was interesting to look at these studies. And what he also found was that both studies on depression and both studies on ketamine, oral ketamine in patients with pain, the treatment was very well tolerated. So, it was an interesting option to look at. So that's why we conducted a pilot study. And as you can see here on our slide, we included 7 patients in this study. We treated them with daily oral esketamine, low doses for 3 weeks. And as you can see, there were 4 patients with, quite okay results. And the treatment was also very well tolerated. None of the patients dropped out. And all patients were, quite okay with the treatment. However, we didn't see any full response and we didn't see any remission in our patients. So that's why we extended the treatment period before we conducted our RCT. And in the meantime, there were some more results. An RCT by Yavlinia in 2016, an RCT by Adepsade in 2018, and an RCT by Domani in 2018. And as you can see on the slide, all these studies show that it's indeed possible to relieve symptoms of depression by treating patients with oral ketamine. So this was quite hopeful. And then we had our RCT. And our study featured a triple-blind, multi-center randomized controlled trial. And we treated the patients with thrice daily esketamine, 30 milligrams, or we gave them an inactive placebo. And it was an add-on to regular antidepressant medication. And the treatment period was 6 weeks, and we had a follow-up of 4 more weeks. We included adult patients with a unipolar depressive disorder. All of them had at least a moderately severe depression. And all of them had at least insufficient response lifetime to 3 or more different classes of antidepressants. And we randomized 113 patients. Almost 58% of them were female, and they had an average age of almost 52 years. And in their history, they had, on average, 4.4 depressive episodes. And their current episode was 9.3 years, so that's quite long. And they, on average, use 6.3 antidepressants in their current episode. And 40% or 41% of them also had electroshock therapy in their current episode. And there were even more patients that had ECT in their history. And finally, 65% of them also had a comorbid psychiatric disorder, XS1 disorder. Now, when looking at the results, of the oral esketamine 30 milligrams twice daily compared to the placebo. We didn't see spectacular things, unfortunately. When looking at the Hamilton Depression Scale, as you can see, there was no significant differences between the placebo group and the esketamine group. When looking at the response rate, we had a 3.5 response rate in our esketamine group and 8.9% in our placebo group. So even a bit more responders in the placebo group. However, the difference was not statistically significant. When looking at the self-rated IDS, there was no difference between the two groups. When looking at anxiety measured by the BI, there was no difference between the two groups. And when looking at suicidality, the severity of suicidality, there was also no difference between the two groups. So this is quite not in line with the results of yesterday and not in line with the results of Professor Glue we just heard. So how come? Is it because we treat our patients daily? Is it because we treat our patients with esketamine instead of racemic ketamine, or with oral instead of IV or intranasal? Does it have anything to do with the duration of their episodes or the treatment-resistant severity? Does it have anything to do with the blinding? We also looked at the blinding, and we're still analyzing the results, but it seemed like most patients, only 15% of the patients that received ketamine knew that they had ketamine. So does that have anything to do with it? Many options, and we are really looking forward to your suggestions about this. And my final slide about safety. These findings are hopeful. Dropout rates were similar between the two groups. Unfortunately, we had 2 suicides, but in both arms. So we had 1 suicide in the placebo arm and 1 in the ketamine arm. And when looking at dissociation, we saw a slight increase in the esketamine group and interesting, a slight decrease in the placebo group. And this difference between the 2 groups was significant. However, we had no dropouts due to dissociation. And we're looking at the SAFTI. It's a 52-item measurement looking at all different types of potential adverse events. We only saw differences regarding feeling nervous or feeling hyper, and dizziness or faintness or dizziness when standing up. So altogether, treatment was very well tolerated. And so that's about the RCT.
Thank you. Parallel to the randomized controlled trial, we offered an off-label treatment program. And I will show you the results of the patients that we've been treating up until this point. The off-label treatment program was offered to patients with treatment resistance, defined as insufficient effect of 3 types of antidepressants. And we offered the treatment for 6 weeks in an inpatient setting or a day clinic setting. And the oral esketamine treatment was given twice weekly with a starting dose of 0.5 or 1 milligrams per kilogram. And then it was titrated individually to a maximum of 3 milligrams per kilogram. And we titrated the doses based on the acute side effects and also the antidepressant effects. The esketamine was given as an add-on to other antidepressants, including the monoamine oxidase inhibitors. And we evaluated the treatment after 6 weeks and then offered patients also the option to continue maintenance treatment at home. These are the baseline characteristics of our sample. The sample consisted of 162 patients. Most of them were diagnosed with MDD, but 11% suffered bipolar depression. The average duration of the current depressive episode was 50 months, and patients had been experiencing an average of 9 previous depressive episodes and also tried on average 9 antidepressants up until that esketamine treatment. 60% of them also had a history of ECT. Also, more than half of them had a comorbid psychiatric disorder. So we found our patients to be extremely treatment resistant, we think. The baseline severity of the depression was an average of 21 points on the Hamilton score. When we look at the 6 weeks treatment, the dropout rate was 9%, so 15 patients dropped out during the first 6 weeks, most of them because of insufficient improvement, in some cases also because of a combination with side effects as dizziness, anxiety, an increase in PTSD symptoms in 2 patients. They suffered from flashbacks induced by the ketamine. And in 3 other patients, there were other reasons for dropout, so COVID restrictions, cannabis use, and the travel time. And when we look at the results, we found a significant effect of the esketamine treatment on the depression severity. So the Hamilton total score decreased from 21 to 16 points. 41% of the patients wanted to continue treatment after those 6 weeks, so they entered the maintenance phase. Among the patients from who we had complete Hamilton data, we found that 44% had a minimal clinically important difference. So 44% had a decrease of at least 27% on the Hamilton score. And we found response and remission in 26 and 16%. So we think that's strikingly different from what we heard in the talk earlier this morning. Among the 97 patients who had suicidal ideation at baseline, so they scored more than 0 on the Hamilton suicide item at baseline, we found that a third of them achieved complete remission after 6 weeks, and more than half also we saw a decrease of the suicide item score. Looking at the side effects, we assessed the SAFTI again at week 6 and also at baseline, and we compared those scores. So it's not really the acute side effects, but we looked at the side effects over the 6 weeks, and we found these symptoms to occur most frequently. So in more than 10% of the patients, we found an increase in dizziness, feeling nervous, constipation, problems sleeping, abnormal sensations, headache, and weakness. We found no evidence of urinary tract symptoms. The cognitive functions, we saw an improvement on the MoCA score, and we did see a significant increase in dissociative symptoms, but again, no correlation with the Hamilton change. In summary, we think oral administration of ketamine or esketamine shows advantages such as the costs and the possibility of at-home use for patients. However, data are relatively scarce. We found no efficacy of the low-dose thrice-daily esketamine when we compared it to placebo, but we think our results from the off-label treatment program were promising, using another treatment dosing regimen with the individually dosed higher dosages, often twice weekly. But we do question, why are the results so different from what we've heard before or what we hear in the literature? This is our study team in the Netherlands, and thank you for your attention.
Fantastic. Yeah, any questions for our 2 speakers? Maybe at the back, and then to you here.
Thank you for the presentation, Roger. Ronald, with the capsules, did you previously or contemporaneously, have you done pharmacokinetic studies with this delivery method? Obviously getting at the question of bioavailability.
Yeah, I think that's a good question. No, we have not. No. We did look at the bioavailability of oral esketamine in studies by Fanta and Paltonimi. I don't know, I'm not sure if I pronounce it correctly, but we used those studies in healthy volunteers, looking at the bioavailability of oral esketamine, and that's what we used for the calculation of our dosing regimen in the off-label treatment. And I prepared a slide for that as well. Let me just, maybe in the meantime, what we did do was we looked at the blood levels of esketamine and also the noresketamine, but we're still analyzing these data. But we're curious about the relationship with the blood levels and the difference in the Hamilton scores.
Great, thank you. So we go, your question here. Thank you.
Hi, Esther Hagai from Flexio. So regarding your LCT, could it be that the patient's population you included was very refractory when you looked at the characteristics, I think that they are much more refractory than what you can see in other TRD studies, in particular the number of previous failures, the patients having ECT. So do you have an opinion about that?
Am I still working? Yeah. I think we do have had a very difficult to treat population, potentially more difficult to treat compared to other studies. However, there are also studies studying really treatment-resistant patients and still finding better results. So I'm not sure how big the role of the treatment resistance is, but it's indeed something we have in mind.
That's great. Thank you very much. We won't have time for more questions. We're going to move on, but you'll be around in the coffee break as well, I'm sure. So thank you very much.